Thank you very much, Stella, and good morning, everyone. I have to apologise. I'm a bit old-fashioned and I'm not using slides, so I'm just going to speak. Keep it a little bit different. So, a renewed vision for the NHS, I think, is quite a topic, quite a challenge to handle, particularly given the pressures that we've got today. We're talking about that in the context of the NHS long-term plan. So let's rewind the clock back to 2019, when NHS England published its long-term plan, which was a package of commitments made to accompany the NHS funding settlement the previous year. And it set out briefly what the health service was going to do with the additional £20.5 billion that had been given and what had been branded its 70th birthday present. I think at the time the long-term plan was broadly welcomed by health leaders across different organisations, and in particular that shift towards expanding community, primary and mental health services. But as Stella rightly said, since the publication of the long-term plan, the world has changed. In COVID-19, the NHS and public health more widely has faced what's probably been its biggest ever challenge. No part of the long-term plan has been unaffected by the pandemic. And the pressures from COVID, combined with a relative period of relatively low historical funding for the NHS, demographic challenge of an ageing population, and less healthy lifestyles, has left the NHS perhaps in the worst crisis in its history, with some of the longest waiting times on record and stagnating life expectancy over the past decade as well. And this is despite the heroic efforts of clinicians, managers, administrative and support staff. But the overall picture is one of significantly increased demand on services, delays in access, increased inequalities in population health outcomes as well. And the recent British Attitudes survey showed that while the public is still overwhelmingly in favour of the blueprint, the vision and the founding principles behind the NHS, that more people are now dissatisfied than satisfied with services, and the current trajectory isn't particularly pretty. But if wars are the locomotives of history, then pandemics are certainly the locomotives of health policy. While longer-term pressures have been accelerated through the pandemic, we've actually seen some areas of progress as well. So the NHS has delivered its long-term plan commitments in areas from remote access to primary and outpatient care, consultations, increasing support for mental health in schools, 24/7 access to mental health crisis support has been stepped up, and we set up new primary care networks across the country that have been instrumental in our COVID vaccine rollout. And of course, as well as the pandemic, the legislative landscape has changed since the long-term plan came out. We've had the Health and Care Act 2022, which has created new statutory organisations, committees which make up integrated care systems, and set new objectives and enshrined in law the duty to collaborate, a fundamental shift from competition towards collaboration in how we organise our healthcare services. And as we discussed at the GovConnect conference a few months ago here on integrated care, I argued integrated care systems present a new vision for health and care. They've been created to address this underlying structural problem that simply the rate of increasing demand for services is going faster than we can keep up with the capacity to meet it. And they've been tasked with a leftward shift in services from acute to keeping people at home and prevention, and doing that through collaboration with local partners. NHS, local government, social care, voluntary community and social enterprise sector, all collaborating together to achieve. Now that's the vision. But as our Chief Executive, Matthew Taylor of the NHS Confed outlined in his speech incidentally here last night in his Stevens lecture, the solution to the challenges that the health and care systems faces today is proper health policy, not just an ill health policy. The shift to prevention is not as nice to have once we've dealt with the problems around access and waiting times. It's the solution to them now. But this requires collaboration both at a local and a national level. I think with 80% of the wider determinants of health determined by interventions and services outside the remit of the Department of Health and Social Care, this will require a more joined-up approach from the government if we're going to get it right. So if that's the vision, what then is a renewed vision for the NHS as we look forward to its 75th birthday? I think this time it's probably not a long list of deliverables from the centre, Rather, we need a plan to actually unlock the potential of integrated care systems as already been set out to deliver that vision behind them. Ultimately, change and improvement happens when you've got strong local leadership, the agency to act on it, and partners collaborating. And I'd argue, fortunately, Patricia Hewitt has, in her recent review, has set out some proposals of how we get there. The Hewitt review presents a vision for a much less centralised approach to enable and renew the vision behind integrated care systems. The reality is that you cannot run a system as large and complex as the NHS, all from Whitehall, effectively. To enable and drive innovation, we must evolve to evolve. The Hewitt Review proposals reinforce that preventative vision of ICSs, and we so often heard leaders, from ICBs, ICPs, and in the wider system through the review process saying this is why we took on the job, that vision of prevention, improving population health outcomes, tackling health inequalities. So, perhaps rather than an action plan, the Hewitt Review offers a vision for a long-term strategy to how we create those conditions for success in a very difficult climate. And it does make some specific proposals to help to do that. So you haven't had time to read all 89 pages and 32 recommendations, which will certainly be forgiven for. Let me just pick out what I think we see as 8 key proposals in the review that could make the biggest difference for helping systems to flourish. Firstly is on prevention. We've consistently heard from leaders in different parts of systems that actually prevention is their key priority. To achieve this, cross-government collaboration and a shared language between government departments is essential. And the review makes a specific proposal as well to shift 1% of spending towards prevention over 5 years, which I think is a useful tool to help refocus the machinery of government, but certainly should be seen as a floor rather than a ceiling. And a clear definition of prevention, what we mean by preventative services, is needed as the foundation to underpin that. Secondly, fewer, more focused national targets, perhaps one of the headlines that came out of the review in the press. A smaller number of national targets, ideally no more than 10, with equal weight for local priorities, to be able to help systems really focus and get on with delivery. This should build on the positive and more streamlined approach that's already been taken in NHS England's planning guidance for 2023 that came out in December, but also still go further. Thirdly, rather technically around allocations and payment mechanisms. Achieving a shift towards prevention requires appropriate funding flexibility within systems in order to be able to do that, and the appropriate incentives as well. Rolling a greater share of the funding that goes into systems, into their overall allocations, rather than, as we often see, a kind of a drip of funding that often comes with a lot of data reporting requirements that can have extra administrative burden onto systems, would be a really important start. And on top of that, an immediate change in the NHS payment scheme guidance to allow for flexibility, where ICBs and providers agree in terms of how those payments are made, so that incentive towards prevention can pan out in how we spend our money. Regulation as well, as the only national body with a remit across all of systems, including the NHS and social care. I think there's an opportunity for the CQC to play a greater role supporting and driving improvement. And this should be at the heart of the CQC's new role to regulating systems. And it provides an opportunity to, with greater autonomy comes greater accountability. And while it can be politically expedient sometimes to call for a cut on NHS managers, let's remember that the NHS is one of the lowest levels of management of any healthcare system in the world, and certainly lower than other sectors comparably domestically. Actually delivering change in local services, reforming local pathways, requires headspace, it requires time, it requires analysis, it requires investment. And so I think we'd welcome seeing the forthcoming cut to ICB's running cost allowances to be scaled back from 30 to 20%, which would allow the NHS to spend more time actually getting on with improving services and perhaps less time distracted by reorganising internally. A lack of availability to existing capital budgets is often a drag on transformation to improve services and productivity. And this is a particular challenge that we've seen, for instance, in rolling out community diagnostic centres and the new hospital programme. And a review of the capital sign-off process, I think, would be urgently welcome in order to improve and address that. And while there's opportunities in the shorter term, I think, to reform the way that payment systems are made, ultimately we have a new vision in integrated care systems, and perhaps we could have a new payment system that goes along with that. And there's an opportunity, I think, to learn from international best practice. How are other countries designing their payment systems to get the incentives to prevention and driving efficiency right, to learn from that and to create something bespoke. And finally, and although this perhaps doesn't touch on the issue of devolution, integrating health and social care at a system level will be hindered by the lack of capacity in social care sector if we don't get this right. And this is for younger adults, not just for older people. We mustn't forget that. Social care can enhance people's life experience and provide preventative services to prevent worsening ill health. And a strategy for the social care workforce to match the one that we're expecting shortly for an NHS workforce plan, I think would be very much welcome to support the sector. So, look, in all of that, I think there is a vision for a more devolved model of health promotion, not just health care. And the 42 integrated care systems, which are all the partners, not just the ICBs, but the Trust, Foundation, just primary care, VCSE, social care, coming together so they have the vision, the ability to innovate, will be key to delivering that. But, I think at the moment it's certainly at risk. A greater centralising and old behaviours are beginning to creep back in and undermine that vision. If we carry on doing the same things we've always done, then we can't expect any different results. As we look ahead to a potential general election next year, the political debate around health is naturally going to focus on waiting times, being able to see a GP, being able to find an NHS dentist. And these are really important issues, and that shouldn't be shied away from. But I think that the question then is how do we address these factors? And the best way to do that is by enabling local leaders to keep more people healthy in the first place and empowering them to do that. So for its 75th birthday present, in the face of some of the greatest pressures that it's seen, the NHS and the wider healthcare system, I think first it needs our trust, but it also needs our support to deliver this vision, so that we can really empower it to get on with the vision that's been set. Thank you very much.
Turn this off. That's wonderfully well timed, and actually it gives us a few minutes for some questions. There is a formal Q&A a little bit later on, but are there any immediate questions for Ed? They're still thinking about their breakfast, I can tell.
So am I.
May I just ask then in the audience, forgive me if I miss out any huge categories, operational leaders in the room, can I just have hands up, just in terms of who our audience are? Clinical leaders? Who else do I have? Who else is in the audience?
HR professionals.
Lovely. Let's have HR professionals.
Improvement specialists.
Lovely. Improvement specialists. Hands up. Lovely. Who else do I have in the room?
Healthcare consultants.
Wonderful. Hands up, healthcare consultants. Lovely. Now, there are still people who haven't put their hands up. Still people haven't put their hands up. Who else is in the room?
With pharmaceutical industry.
Wonderful. So industry colleagues? Wonderful. Have I missed anyone out? Forgive me, I'm deaf in one ear, so it means I cannot tell where voices are coming from. Who was speaking just then?
Third sector organisations.
Wonderful, and I must never forget third sector organisations. So hands up in terms of colleagues. Wonderful. Wonderful. So have I covered almost everyone? Yes. Trade unions, thank you. And anyone else? Yes, please.
Academic Health Science.
Wonderful, wonderful. So, the beauty of today is that you've got colleagues here, and the Q&A is often as important, if not more important than the conversations, because you can really put people into, you know, the question mode and ask them the difficult questions that you can't ask at any other time. So, Ed, I think you've been let off the hook for now, but they're going to think about questions. Yes, please. Oh,
Well, I've got one of those.
yeah, no, absolutely.
James Hargrave from Daiichi Sankyo. I was just wondering, do you think the major conditions strategy, I think the ship sailed. James Hargrave from Daiichi Sankyo. Do you think the major conditions strategy is going to sort of breathe any new life into the long-term plan? Because obviously there were some very ambitious disease area targets in the long-term plan. Do you think the major condition strategy will kind of reinvigorate meeting them, or be something completely separate and its own living document?
Yeah, thank you. It's a good question. So look, I think I'll probably start off with acknowledging that the major condition strategy pulled together a number of things that were in the works beforehand. And I think there's a balance to be struck between not having a separate strategy for everything and doing things in silos and taking a proper holistic view, but also being able to get into the level of detail, and giving every kind of area of disease and challenge kind of proper time and proper thought through process. And I think that's certainly come out around the major condition strategy. So I think to an extent, yes. Yes, it will do. There'll be things in there that will be hopefully picked up. But again, it's about finding that balance between, what are the things that we need to coordinate on nationally, and again, these shared set of national priorities, but not kind of taking out in the kind of the targets and the aspirations that are set out from the centre, making sure that we balance that with not squeezing out the agency that local systems, local teams have to innovate. So actually they've got more time to look outwards to the needs of patients. What do we need to do particularly in our area rather than constantly looking up?
Thank you very much, Ed. Please think about questions, and there will be time more formally for Q&A a little bit later. Adam, sorry, I forgot about the mic. Thank you very much. That's lovely. Thank you.